I'm excited. I've got Dr. Lara here. She is a superstar in the functional medicine world. She's got a PharmD. She's got multiple postgraduate degrees, and she is without question a comer, a player, and an influencer and an informer. Dr. Lara, how you doing?
Thank you, Dr. Rob. It's a pleasure to be here. I appreciate you having me on.
Oh, I've been excited. We've been playing a little technological tag, and that's good. But it's really funny. Your name, we were having this conversation about your name and what it rhymes with and how you do it. So I think you got a little story behind it.
I do. So my name is pronounced Lara Zakaria, and very often people mispronounce my last name as Zakaria or some variation of that because it has a Mediterranean link. However, I'm Middle Eastern, and so it's pronounced Zakaria, and I like to honor my family with maintaining that pronunciation. But I moved to the US when I was in fourth grade. And when we moved, as kids do in the fourth grade, they love to give you nicknames, and they're not always the nicest nicknames. And so as a fourth grader, I was often teased as Zachariah Diarrhea. So they would often call me Lara Diarrhea, or some version of that, right? And so that was kind of how it stuck, right? Fast forward years later, one of my favorite things to talk about is talking about how to use stool testing, how to talk about, irregularities in bowel motility. I talk about constipation all the time. I talk about diarrhea all the time. And one of the big things is, kind of talking with my patients about what their stool consistency looks like. And very often, as we know, IBS is a huge issue. And so I get to have very frank conversations with my patients and with my audience on social media about what their stool is telling them about their digestive health. And as we know, that's a foundational aspect when it comes to how well you're absorbing your nutrients and how well things are moving through your body and how well you're detoxifying and removing toxins and excess hormones and all those things. So I always joke, I'm grateful to those fourth graders that gave me that nickname, because jokes on them, I now travel around the country talking about diarrhea and how important it is as a marker for your intestinal health.
Outstanding. That's a great story. Since we're talking about nutrient depletion, absorption, one of the big things out there, it's a hot ticket item now, is the idea of medication and nutrient interaction and depletion. And, with your stellar background, I'm hoping that you can tackle that for a lot of our followers.
Absolutely. So I first and foremost have to say that we don't have a ton of research around drug-induced nutrient depletion, drug-herb interactions. That whole area is sort of scant. And a lot of the research that we do have in that space tends to be lower level research, meaning that if a RCT trial or a meta-analysis is the highest level of research that gives us the most data and the most reliable data for us to make clinical decisions. The type of data that we have researching drug-induced nutrient depletions or DINDs or drug-herb interactions tend to be either animal studies or theoretical studies or case studies, meaning that we can't fully extrapolate them. We can't take the evidence and then always say, this is how we would proceed clinically as a result of that. We very rarely have comparative trials, and we very rarely have trials that try an intervention, like try to actually replete certain nutrients and then see if that actually helped reduce side effects or symptoms or anything like that. So I think it's really important context to understand, because one, I'd invite everybody to join me in advocating for more research in this space, because I think it's really important for us to learn more about that area. And two, for us to understand that when you hear somebody talking about this, that we're making sure that it's evidence informed, that they're talking about it from a space where they can see the clinical implications, they understand what is going to be relevant and what isn't. And there are some that are well established. I'll give you an example. We know that statins do deplete CoQ10. We know that methotrexate is actually what's required that we give folate or folic acid at the same time. So there are some drug-induced nutrient depletions that are very well established. There are others, however, that we are less aware of. And then there's going to be factors, clinical factors, environmental factors, digestive factors that are going to impact how much of an impact that interaction is going to have on your body.
Great stuff. That's a lot to unpack. So I'm going to hit you with a couple over-the-counter medication that depletes important nutrients. So when I'm done with the list, I'm curious to hear
Okay.
what you feel about the list. Number one, we'll talk about Tylenol, known to deplete coenzyme Q10 and glutathione. Aspirin, folic acid, and B vitamins, vitamin D, calcium, iron, and the like. NSAIDs, non-steroid anti-inflammatories, which do decrease pain but impair healing. They increase the incidence of leaky gut. So they're known to deplete folic acid, B vitamins, calcium, iron. You did a great job with the statins, coenzyme Q10, known. And lastly, female hormones. I know you talk about that a lot. Estrogen depleting folic acid in B6.
Okay. So I'm going to start with the ones that really stand out to me. The first one is Tylenol. So people often confuse Tylenol with ibuprofen. Tylenol is a different anti-inflammatory category. It's actually not even technically a great anti-inflammatory. What it does is sort of numbs the signaling to the brain. And so that sort of depletes like the amount of pain that we feel as a result. Unlike NSAIDs or even aspirin that you mentioned, which have a direct anti-inflammatory effect. They work on parts of the COX enzyme that is part of the prostaglandin cascade. So a lot of big words basically saying that the specific cascade that turns on inflammation or turns off inflammation. So I want to make sure that those categories are clear. That's why there's slightly different side effect profiles and slightly different things that we have to worry about. With Tylenol, the biggest thing that happens is the depletion of glutathione. And that's really well established actually in the research, because we know Tylenol overdose, we know impacts the levels of a compound called N-acetylcysteine, or NAC, NAC for short. That is a precursor, is one of the main precursors to making glutathione. And glutathione, for a refresher for everybody, if they're listening to your podcast, they're probably well aware, is the master antioxidant. It's a major compound for turning off oxidative stress. And oxidative stress is happening in our body at all times. All the systems and mechanisms that we have to keep us alive, to turn on metabolism, create oxidative stress. And we have all these systems in place to turn off that oxidative stress, and glutathione is sort of the master key for that whole process. So when you take too much Tylenol, you start depleting that NAC, and that means that you're going to deplete glutathione. In low levels over time, if you're not replenishing that NAC, you're going to eventually deplete glutathione, and that's going to start with causing liver damage, but that could, over time, that starts to, as we know, systems medicine, everything's connected, that starts to impact other organs and inflammation, and starts to set off other issues throughout the body. However, specifically in Tylenol overdose, people take a whole ton of Tylenol all at the same time. What ends up happening is you very quickly deplete that NAC, and that's often what leads to death. And that's why in the hospital, the first thing that they do is they give you large doses of NAC to counter the Tylenol. So we know for a fact that that happens. Where we don't know is how long is it going to take? How many years? What dose of Tylenol does it take to deplete NAC and glutathione to have a negative effect on the liver? We don't know that specifically, and it's likely going to be dependent on various factors, your specific organ system, what your biochemistry looks like, what your environment looks like, what your needs are, and what your nutritional status looks like. So it's a lot of different factors that go into understanding that. So if you're in the habit of taking a lot of Tylenol for managing pain and it seems to work for you, that is safer on your stomach. That's less likely to cause GI bleed, less likely to cause kidney issues. From that perspective, safer. However, more likely to cause liver issues and more likely to cause glutathione depletion and increased oxidative stress. So I usually recommend, if necessary, to pair that Tylenol with NAC or glutathione so that we can replete some of that antioxidant.
You know, interestingly enough, when you're talking about glutathione, the master antioxidant, especially if it's absorbed in the cell, so I like a liposomal form. The NAC produces the glutathione. Glutathione depletion, which does occur naturally as we age, is one of the big reasons for tight junction in the gut damage. So again, taking Tylenol, as you alluded to, can lead you down the slippery slope of damaging your tight junctions, increasing your zonulin and protein and enzymes and occludin enzymes, and also leading you down this slippery slope of leaky gut, where you're not going to be able to absorb the nutrients, which is what you were talking about and kind of referring to sort of like
It
a
becomes a
tornado, if you will.
catch-22, right? And who do I think of when I think of consistent Tylenol usage? I think of the very young and I think of the elderly, right? Because usually we're using Tylenol to manage fevers, colds, flus, that type of thing in the young. And then I think of Tylenol use in the elderly with increased arthritis, aches, pains, et cetera. And those are going to be probably the two populations that are going to be the most sensitive to this depletion of glutathione as well, right? And what's happening in the liver with very high metabolic states, whether it be in the children or it be in older adults, you've got these active metabolic states that are putting even more pressure on the liver. So another piece, another sort of little pearl here is milk thistle. Milk thistle is an herb that has been shown to be protective against damage to the liver, particularly damage from Tylenol or acetaminophen to the liver as well. So kind of pairing those two together can be a really nice way to help protect the liver if it's inevitable to use Tylenol. And there are options and alternatives to Tylenol. We can get to that another day, but that if you find yourself in a situation where you're using Tylenol, I would say more than a couple of days in a row, it's a really good idea to pair it with at least NAC. I like your idea of the glutathione, the liposomal glutathione. That could be very expensive, especially to get a high quality liposomal. So I find NAC to be a great, more accessible alternative if price is an issue.
So if someone's taking Tylenol to wrap it up in a tight ball, we recommend from the functional medicine side to ameliorate or at least attenuate some of the side effects. We would add NAC or liposomal glutathione and milk thistle, and that would be our protocol. I'm going to throw one at you. JAMA 2023 talked about aspirin. They said a daily use of low-dose aspirin offers no significant protection against stroke and was linked to a higher rate of bleeding in the brain. 38% higher rate of brain bleeds for people who took aspirin daily compared to those who took placebo. It has been stated that if the FDA had to look at aspirin again today, it probably wouldn't pass it as a drug or over-the-counter usage.
Yeah. You're reminding me of, I want to say it was like 2000, it was the early 2000s, a while ago. A study came out about aspirin, about it potentially being a useful prophylaxis, not just for cardiovascular disease, but they were looking at it for other disease states like diabetes and endocrine disorders, et cetera. And, in hindsight, I can look back at that and go, oh, that's cute. What they discovered was that inflammation is a key driver for cardiovascular risk, as well as with other chronic diseases. They accidentally stumbled on that piece of information before it became more kind of common knowledge. And, they abandoned it because of the increased risk of bleeding. And I think to your point, they found at the time it wasn't statistically significantly more improved outcomes as a result of using aspirin in that way. But we kept on using it because of its blood thinning effect. So we don't use aspirin because it's an anti-inflammatory. We use it because it has a blood thinning effect. And the idea that thinning the blood then reduces the risk of plaque formation and bleeding. Essentially, we're thinking about it as plumbing, and we're thinking about the circulation of all the things that's carried in the blood are less likely to sort of get stuck in the plumbing if the blood is thinner and can move through. The unfortunate side effect of that is now you have thinner blood, meaning that if there is a rupture somewhere, the ability for the body to then plug that hole is reduced because we've literally given it something to prevent the clotting, to prevent it from being able to plug that hole. So you're left with this question: how effective is the thinning of the blood against how much of a risk is there for arterial damage and then potentially bleeding? And in folks who are in an increased risk of cardiovascular disease, heart disease, et cetera, you're more likely to have sprung a leak somewhere in the very delicate capillaries in the brain and the parts of the body that are more prone to having that elevated risk, and therefore that increased chance of springing a leak. And if you're on the aspirin, you're more likely to have that have that effect. I think it's really interesting because I'm sort of on the fence on it. I think there's going to be certain individual whose risk of cardiovascular disease is so high that I'm more willing to say, you know what, it doesn't harm to do a very low dose aspirin in those cases, because we really want to prevent the chance of them having some sort of cardiovascular event. That said, Now, the studies show that the enteric-coated aspirin doesn't have the same benefit as the plain old, chewable or the uncoated aspirin. So now we're increasing the risk, especially over the course of time. They're taking it every day for years and years and years. We're increasing the risk of GI issues. And now we go back to that same foundational principle. If you're increasing the risk of intestinal permeability, that means you're increasing the risk of dysbiosis or alterations of the microbiome. You're increasing the risk of the digestive enzymes not having as active of a role in the way they break down proteins, and our ability to then digest fat is altered. All of that starts to become sort of this like smoking cauldron of potential risk that's going to elevate their potential risk for a cardiovascular event. And if we look at Dr. Mark Houston's approach to cardiovascular risk, where he's very heavily emphasizing the reduction of inflammation as a driver, those factors that I just mentioned that change the way our gut functions and alter the way that we absorb nutrients and antioxidants can potentially be a bigger driver of that inflammation and might outrank the effect of just thinning the blood on its own.
Wow, there's a lot to unpack there, and you opened the door to this conversation. Aspirin versus omega-3 fatty acids. Can you differentiate how they function, or do they have the same function? Are they replaceable? So I get a lot of patients that say, hey, what's the story? Would you take an aspirin or omega-3 fatty acid? And then you talked about clotting. What about vitamin K?
Okay. We're getting into some nitty gritty nuance. So I hope if you're listening that you've got a pen and paper, because we got to write all this down. It's too juicy. Okay. So first, the mechanisms that an NSAID or specifically aspirin work are a little bit more like a hammer on a nail, right? They are being very specific. I alluded to earlier the COX mechanisms, right? We actually have multiple prostaglandin pathways, and we have COX and LOX, so COX and LOX enzymes that modulate the direction in which those prostaglandin enzymes go. And we associate prostaglandins with increased inflammation, but prostaglandins can also neutralize inflammation. So depending on sort of which whack-a-mole you hit, you're either going to get more inflammation or you're actually going to neutralize some of the inflammation. And it's meant to be sort of this balanced approach. When we take an NSAID, again, specifically an aspirin, which is an NSAID, you're going to hit one of those COX very deliberately, right? It's less specific than, say, Celebrex is, which is a very specific COX-2 inhibitor. It's more general, but it's still going to only hit the inflammatory parts, but that's going to start to impact our ability to then neutralize inflammation at the same time. So you end up getting this sort of imperfect sudden halt to inflammation, but then you also don't get the neutralization of inflammation. Now, on the other side, you've got omega-3s, and I don't like to talk omega-3s on their own. I think it's important to understand that omega-3s are actually need to be in balance to omega-6s. So zooming even further out, part of the benefit of adding omega-3s is that the majority of the US population tends to have a higher omega-6 to omega-3 ratio. We're supposed to have about 4-to-1, 4 times more omega-6 to omega-3, but we tend to have somewhere in the 20s. Some of the more, some of the studies that I've seen say up to like 20, 24, 25-to-1 ratio. And that has to do with the way our diets are and our lean, the way that we lean on more processed foods tends to favor omega-6s over omega-3s. And a lot of people, I don't know, I've met a lot of these people that don't like fish, and fish is a major source of omega-3. So you combine those two factors, you get this really exaggerated ratio, and that is a driver of inflammation. One of the ways that we can neutralize that is by improving that ratio. So by taking an omega-3, you can neutralize that ratio. But if you already have a good ratio of omega-6 to omega-3, that on its own isn't going to necessarily improve your inflammation. It's not the more is better. We actually need it to be at the right ratio of about 3-to-1 for us to have good balanced immune response. On the other end of it, you go too high on the omega-3, you actually get insufficient immune response, and then you open yourself up to a whole other sort of immune imbalance. So I think there's a little nuance there in terms of how much omega-6 or omega-3 you're getting. But what's kind of interesting about the omega-3s is they have multiple benefits, largely because of their more nuanced approach in how they neutralize and balance inflammation is actually a better word. What they do is they help to support the right inflammatory response to help neutralize any potential threat, but they at the same time improve what's called the resolution of inflammation. So they're the off switch. When we have too much inflammation, it keeps us from going too far over the edge. And aspirin doesn't do that. Aspirin only has one setting, and there's not an off setting to it. Whereas omega-3s, especially a high quality omega-3, one that is really balanced, and even better when you're combining it with food sources as well as sources of polyphenols, that tends to have the best sort of immune modulating effect that ultimately can balance and reduce the risk of having more cardiovascular risk.
Great stuff. You now brought us to another door, opening up to another room where you talked about people who take supplements. Well, the data is interesting in that they take supplements, obviously, to improve overall health. But you made a great point. Buying a supplement, or you alluded to the point, buying a supplement by yourself without having a functional medicine practitioner oversee what you're doing could lead you down a slippery slope, in that you just talked about the ratios being right. Because some data here says individuals who take daily supplements more often self-prescribe their use versus a healthcare practitioner. So this truly increases the possible danger of drug-nutrient interaction. And also, by doing so, they can impair absorption, efficacy, and clearance of medications, as well as the issue with the nutrient being an issue with the right ratios. You really hammered that point home. Want to pass the baton and see where you want to go with that.
So I got a couple of thoughts. Number one, I have super smart patients and clients that come to me, and we always, or at least I try to always run a fatty acid panel. And it's very often they're coming because they know it's important for them to address the omega-6 to omega-3 ratio. And so they're either have started taking an omega-3 supplement, or they are working on their diet and trying to really balance that ratio. And it's actually not surprising to me anymore, but at first it was very surprising to me how often I would find that they would either have a low omega-6 to omega-3 ratio or an ideal omega-6 to omega-3 ratio, yet they still had all the symptoms of inflammation. So I think, to your point, making sure that you are getting the data that you need to personalize the approach. Supplements aren't just, they do need a nuanced approach, and there can be problems. You can get reactions. You can actually have the counter effect that you're looking for if we're not choosing the right supplement in the right person. So I always say right supplement, right dose, right person for the right duration. The other piece of it is too, omega-3s. If I had to pick one supplement for you to take a high quality supplement on, the one that you're going to splurge on, omega-3s would be the one. I appreciate that there are prescription omega-3s. However, they're stripped down to the eicosanoids, so they don't have the full spectrum of fats that the fish oils that you see over the counter have. So if that's the only thing you can afford and your insurance covers it, it's better than nothing, in my opinion. But if you can, next step that's better would be to get an over-the-counter fish oil. From there, it's really important that we choose the right quality fish oil. Not all fish oils over the counter are alike, and some do a better job in screening for and ensuring, one, that there's no mercury. I think we're all aware that there could be mercury contamination because we're getting it from the water / from fish. And two, in the processing of the fish oil, if it's not processed in the right way in order to protect and preserve the integrity of those fats, you can get rancidity. And it's, so imagine you've got this long string of these long fatty acids, right? They are kind of held together by very loose strings. Too much jostling in the form of heat or processing can break those bonds and denature them, so that the integrity of that fat is no longer the same. It starts to shift it to become an inflammatory fat. So you could be inadvertently taking a low quality fish oil, might be contaminated, worse, might be actually creating a more inflammatory effect. And so that in and of itself is my word of warning to get a higher quality fish oil from a company. I like the professional lines that have extra steps and extra safety measures by third parties to ensure that the quality of the fish oil is kept intact. And a clue that there might be some rancidity in your fish oil would be that you have a fish taste afterwards. If you're burping up fish afterwards, that's rancid. There's something wrong with it. It's okay to have a little bit of a fish smell if you're particularly sensitive to that smell, but when you're sort of burping it up for a while afterwards, that's typically indicative that that's probably not the best quality, or it's expired, or something has happened in the process of getting it off from the shelf to your house, that maybe it got overheated or something like that. So just be mindful that that's not typical. You shouldn't be experiencing that. Then the third thought I had is, to your point about making sure that we're aware of the potential interactions. There's a statistic that about 40% of people who take a supplement and a prescription do not articulate that fact to their clinician. They don't tell their pharmacist, they don't tell their doctor, the prescriber, that they are taking a supplement. And very often it's because they don't think that they'll be heard out. Very often they feel like the clinician may kind of dismiss that supplement, or won't have a compassionate conversation about why they want to take that supplement, or force them to get off of the supplement. And so I think that is a note to any clinicians that are listening, for us to, even though we might not have had the training in this space, for us to do our best to also hear out our patients and to try to educate ourselves about these drug-herb interactions, drug nutraceutical interactions, and where the potential for even synergistic positive combinations lies.
Great stuff. I want to clarify and recap. Number
Yeah.
one, you said the prescription omega-3s is only EPA. There's no DHA in there. Is that correct?
It's EPA, and it's very specific form of EPA that has been extracted, and that is out of balance. So it's not just even that it's just EPA versus DHA. It's a very specific extract, and it's very what's the word I'm looking for? It's isolated and sort of purified. And fatty acids, if they are not in a balance, if they are not in a spectrum, don't tend to perform as well. And I think that's a lot of the reason that so much of the trials and the analysis on whether or not fish oils are good or not for preventing cardiovascular risk come down to, we're not looking at them in terms of their spectrum and how they work synergistically within the food matrix. We're looking at them in isolated components, which is sort of missing the mark in terms of how fatty acids actually function in the body.
So the ratios, my understanding, correct me or add to it, is that you want an EPA to DHA for inflammation, pain, overall usage in approximately 3-to-2 ratio. Whereas if you want more cognitive effect, you want more DHA.
Correct. Generally speaking, higher DHA is going to be useful neurologically. So whether that be for cognitive effect, for preventing dementia, for helping with things like Parkinson's, et cetera. I've used it as we of course we use it in children, prenatally, et cetera. But there's actually some interesting research that's starting to point at DHA as potentially being useful for the cardiac muscle function as well. And so we might have been or I should say underestimating the benefit of DHA on the cardiac impact as well. So generally speaking, EPA can be really helpful for cardiac risk, but that's largely because of its impact on the liver, on insulin resistance, and on the fluffiness and the reduction of oxidized LDL. So reducing sort of the damage that happens to the circulating cholesterols. But the DHA might have a more direct impact on the transmission and the rhythmic function of the cardiac muscle, which might be actually more helpful for arrhythmias or for just improving elasticity in the cardiac muscle in general.
Great stuff. Now, you talked about the synergy also between nutrients. Some examples I want to share with you and open up the gateway so you can add some more would be clearly a pre and probiotic. Probiotic to give life. A prebiotic is the food for the probiotic to foster itself and ultimately make what we like to refer to as a postbiotic, which is what's left. It's its epitaph, and that's the new buzzword in functional medicine. You've got vitamin D3 with K1 and K2. You need the right ratio of that to allow calcium to go to bone and not get addressed in soft tissue. One of the issues with the right ratio is if you drive vitamin D too high, you actually cause a magnesium depletion. So I opened up 2 segues for you to really dig in and go.
Oh, so many. My brain's now going in so many directions. So
Sorry about that.
no, I love it. The magnesium. So I'm going to throw another one in there is calcium. Calcium, magnesium, vitamin D, K1, K2 is a really interesting sort of combination of minerals. There's some other minerals as well that are part of this balance, but let's hone in on these guys. So, we've historically given calcium to help improve bone density. And for the longest time, I remember being taught way back in the Stone Ages that we're supposed to take vitamin D in addition to calcium to ensure that the calcium gets into the bone. But never in that conversation at the time did we really consider the other minerals that make up the bone complex. It was really focused on the calcium. In retrospect, we might have been doing some harm there because overall we know that most Americans tend to have very low levels of magnesium. They require more magnesium than they're already getting in their diet. And now we're adding this calcium, which can sort of complicate their risk for kidney complications as well as for calcification within the vasculature. So what's really interesting there is again, it's this idea of the nutrient matrix, the way that these nutrients actually work synergistically, both countering the absorption of each other as well as aiding in the sort of utilization of them. It's its own way of checks and balances. So I think of when you eat something that has calcium in it, if you eat it at the same time with something with iron, the two are going to compete for absorption. Same with zinc. And so that is the first step in sort of that interaction, that nutrient interaction that could potentially be protective. Because when you need more iron, more gateways for iron absorption open up. And so it allows more iron in. So it'll preferentially absorb the iron over the calcium or the zinc. Then you go a little bit further up when you want to build bone and you're in a state where your body is looking to build more bone density. It's going to look for all the minerals that are needed to build the bone. If you only have one of those nutrients available, you're not going to fully form that bone, which could lead to bone loss. Then you need things like magnesium to improve circulating vitamin D levels. So aside from it being part of the bone matrix, we need magnesium to get vitamin D levels in circulation optimized. And we need vitamin D to improve calcium absorption into the bone. So we're sort of missing this idea of like the intricate connection and the innate balance of these nutrients when we just focus on one nutrient and sort of hammer in, especially when we go in super high doses on the one nutrient without accounting for that synergistic effect or that balancing effect that we get from other nutrients. Vitamin K is really interesting because I think we're still learning about it. I want to say it's sort of like the one we've ignored in the conversation about all the fat-soluble vitamins. It sort of gets dismissed. And very interesting because there are different forms of vitamin K. K2 is the one we typically prescribe with vitamin D because it's the safest. It tends to not have as much of an impact in terms of interactions or in terms of risk for bleeds, et cetera. And that vitamin K helps to improve the utilization of vitamin D systemically. So we usually will recommend that together. But different forms of vitamin K are actually also produced by the microflora. So in our body, we're actually making vitamin K. And that's why when we think of antibiotics, you made a great point about the probiotics, prebiotics, postbiotics. Yes, we see a shift in the microflora. We see a shift in an imbalance of the microbiome. But there's also a shift in certain nutrients, including vitamin K being one of them. And so this shift, this dysbiosis might be contributing to vitamin K depletions and to a certain extent, or at least certain forms of vitamin K that then impact, again, on that cascade and that interaction, that bigger picture of the way that the nutrients interact with each other starts to impact the absorption and the utilization of those other nutrients further downstream. So it's just, if I had to kind of like zoom out and give you a takeaway here, it's that these nutrients, yes, there are interactions, but these interactions often resolve themselves when we think about the food matrix and the complexities of the way foods are naturally taken in. And when we have a really healthy, robust digestive system, then we can often get the right balance from our nutrients. And then we could rely on supplementation strategically to bridge the gaps where there's genetic need or environmental increased demand or metabolic increased demand. And so they're targeted that way.
I'm going to flick the switch and I'm going to get into the idea of incorporating herbs into medication management. It's gained a lot of attention. I know you have some resources for people, resources for practitioners that you'd like to share.
Absolutely. So my go-to resource when it comes to herb usage, utilization, interactions, and even drug-induced nutrient depletion is going to be Natural Medicine's database. That's sort of my go-to. I like the way that they stratify the information. It's updated regularly, and they give you levels of how useful that data is. So that's been my kind of go-to resource whenever I want to look something up, and then from there I might dive a little bit deeper into the literature and look a little bit more. There's another resource, I believe it's called Examine, which also has similar data that a few colleagues have started to recommend and is gaining some traction as well. So I have not dug into that. I don't know if you have, Dr. Rob, but that's sort of the new kid on the block when it comes to this conversation.
Yeah, that's
Yeah.
Donnie Wahlberg, if you will.
Yeah. Well
Yeah.
played. Nice
Yeah.
little throwback reference there. So I would say that what's interesting about drug and herb interactions is, and I'd said this before, we don't have a lot of data on the interactions. Very rarely do we see trials. And when we do see trials looking at the potential interactions, they tend to be limited. But that's actually true of drug-drug interactions as well. We do have more data on drug-drug interactions. There's a lot more interest in looking how commonly co-prescribed medications might interact with each other. But again, it's ethically probably not the best idea to give people put people in two arms and prescribe to them a potential drug interaction, or to withhold from them a potential useful life-saving medication. So that type of study is really difficult to do, but that would be probably the best way to study it. So the best data that we have would be retrospective studies, where we see somebody had an incident, or we see a population is likely to have an incident, and then we trail it back and say, oh, it turns out a lot of these people were taking XYZ together. And so that's a lot of the way that we've assessed some of the more, the stronger evidence in terms of these interactions with drugs and herbs. That said, a lot of the data that we have tends to be, again, case studies, animal studies, kind of these smaller studies, kind of looking at the mechanisms and exploring how the mechanisms could potentially be overlapping. So when you start to dig in, as I was digging in, doing more research about the interactions, I noticed that a lot of the levels of the strength of the evidence was very low, and very often did not actually present in real life. There was very few examples in real life where those interactions were problematic. So a great example is St. John's wort. St. John's wort, I think all of us that had pharmacology got drilled into our head, that interacts with everything. It's a very dangerous herb. And for those who aren't familiar with the herb, it has been used historically as an antidepressant. And so it has a really similar mechanism actually to the way the SSRIs were created. In fact, they derived the mechanisms of SSRIs from studying the mechanism of St. John's wort. So as a result, they have overlapping mechanisms in what's called selective serotonin reuptake inhibition. So it stops us from breaking down serotonin, leaves more serotonin in circulation, which the serotonin is associated with improved mood. It's called the happy hormone. So that's one of the reasons that we typically will say, don't take St. John's wort with an SSRI specifically, because you increase the risk of something called serotonin syndrome. So having too much serotonin can also be a bad thing. It's sort of Goldilocks rule. You just have to have the right amount. Too much is too much. So in the case of in that case, yeah, that sort of makes sense to me. We don't want to take that risk, even if it's a minimal risk. We don't want to take that risk. But there's also, it's metabolized through a set of enzymes that's part of our phase 1 detoxification. We have phase 1, phase 2 detoxification. Phase 1 relies on a set of enzymes, the cytochrome P450 systems, and there's hundreds of them. And it overlaps specifically with a number of these specific enzymes that are also responsible for metabolizing a lot of drugs. So a lot of drugs tend to share these metabolic pathways. And so when you have a lot of them concentrated, it sort of drew the lucky straw where it overlaps with most of them. And as a result, we have that was where the warning came in pharmacy school for us, was it's going to overlap with the metabolism of a lot of drugs, and it's either going to make them fail, meaning that they're metabolized too quickly and exit the body, and then we don't have the therapeutic response that we need, or it'll make them toxic, because in certain cases that cytochrome P450 actually activates the drug. And so it activates it too quickly. Now you have too much of that drug. So there's a little nuance there, but essentially that's the theoretic mechanism. But I have yet to come across a specific example where that has occurred. And I don't know that it's been studied. I just don't think anybody's willing to say, here, take some St. John's wort, take your epileptic medicine, and let's see what happens. Just that's not going to be, a very ethical study. And so again, it's weighing the pros and the cons. So for the clinicians listening, for me, where I am is I weigh the pros and the cons. What's the absolute risk of failure here? In the case of, for example, oral contraceptives and St. John's wort, there's an increased risk of therapeutic failure of the oral contraceptive. And so I'm going to be less likely to take that chance, right? In the case of SSRIs, there's an increased risk of serotonin syndrome, which is really serious. I'm going to be less likely to take that chance. But if the potential failure of a medication is not that, is not that serious, for example, there is an interaction between statins and St. John's wort, I might be more willing to take a chance if that individual wants to use St. John's wort. That said, there's always alternatives, right? We can use other agents that have a similar effect on serotonin and on mood, and we don't have to even take the chance on St. John's wort if we really want to be conservative and careful.
Great stuff again. Where can people go to tailor make their nutritional protocols in conjunction with medicines that have been prescribed?
The number one thing that you would do is talk to a functionally trained, nutrition savvy, supplement and nutraceutical educated clinician. That means that you want to, if you're on medication, my first step would be to get that medication screened by a functional medicine trained pharmacist that understands these interactions and can weigh the pros and the cons and the potential risks of using these medications. If from there, if you're working with a prescribing clinician, whether you're working with a physician, a nurse practitioner, a PA that understands these pros and cons, if you're taking nutraceuticals, if you're interested in taking herbals, if you're interested in managing some of your side effects with herbals, I really encourage you to work with a professional or a clinician that understands these interactions. There's opportunities for beneficial use. I can think of NSAIDs right off the bat. NSAIDs, turmeric, and resveratrol have been studied in combination to work to reduce the need for the NSAID and to reduce the side effects of some of those NSAIDs, including GI bleed and intestinal permeability. So there are opportunities for beneficial synergistic activity. And I want to emphasize that there are places where we can use these interactions in a positive way, but sometimes the risk for a negative outcome or increasing your risk or creating some other complication is also there. And it's really important that you're working with somebody that you trust, that you can have these frank conversations with, and that they're going to be open to also working with you, doing the legwork and doing the research needed in order to give a good evidence-informed clinical opinion.
I heard a term that you used. It was actually new to me. Deprescribing. Do you want to go into detail about that? Because
Sure.
like I said, that was very nascent to that theme.
Yeah, so deprescribing, or sometimes called de-escalation, involves the removal of unnecessary or unwanted medications. And it's actually a common practice. Very often you go to your doctor, or you might go to a pharmacist and do a medication therapy management session or an MTM session, and they'll look at your list of medication and go, hey, you've been taking this PPI for the last year. Let's review whether or not you need it. And let's decide if we need to take you off of it. That conversation about taking you off of it and what are the steps necessary to take you off of it is called deprescribing. And in the US, the specialists that are in geriatrics are experts at this. So I know pharmacists, I know physicians that are geriatric specialists, and that's what they do. They're doing a lot of work in reducing what's called polypharmacy, or taking too much pharmaceuticals at the same time, which we know increases the risk of potential drug interactions, increases the risk of hospitalization, therapeutic failure, et cetera. So that is a specialty within geriatrics in the US. In the UK, Australia, and Canada, there's actually organizations dedicated to deprescribing on various levels. They do it for opioids, SSRIs, PPIs, statins. So there's different categories that they essentially have created guidelines for. So it really depends on where you're trained and what your level of comfort is. But all of us that are in the that have pharmacological training tend to have this level of training of understanding, okay, at some point we have to decide when the medication needs to be de-escalated, either the dose brought down or completely removed. And that conversation, I think, is really interesting in the functional medicine space. We often operate from the lens of let's avoid medications at all costs, but there are times where medications are essential, they're life-saving, they're necessary. And I think the strategic use of medications makes sense when we offset it with a foundational diet, lifestyle, and a targeted nutraceutical strategy that's going to offset some of the side effects. So when I talk about deprescribing and de-escalation, I'm talking about taking the guidelines that are available, putting our clinical thinking caps on, understanding the pros and the cons, and working with the patient to understand what their personal goals are, what's working with them, what's not, what side effects need to be blunted, whether or not they need to be on that medication or not, obviously underneath the scope of your practice. And then from there, coming up with a strategy that, again, I call it put the training wheels on. Make sure you address any drug-induced nutrient depletions, address foundational diet, address their gut, make sure that they are pooping every day, right? Making sure that we're checking off all the basic boxes. And then from there, we can start thinking about, okay, would it be appropriate for us to add an additional supplement that might help optimize this medication? For example, I said before, NSAIDs and polyphenols. They recently took an antibiotic. Do we need to approach their gut and either work with a probiotic or do a gut protocol to address what's going on with their gut, right? So kind of thinking through what are those basic steps. And then from there, if it's appropriate to deprescribe, what are the steps? Do we need to taper down? Do we need to slowly, gradually go down like an SSRI or a PPI? We can't just quit that overnight. There needs to be a tapering. And then I always say, again, put those training wheels on, and then I support them nutraceutically or nutritionally with that taper down approach so that their body isn't just suddenly coming down off of that with no support.
So that's in your medicine cabinet overhaul, if you will.
So the deprescribing is a little bit more complex. So when I work with patients who are looking to prescribe, I typically will work with their clinician. I'm never deprescribing anything that they need to be on and without the permission of their prescriber, because I'm not their primary prescriber on it. But in the medicine cabinet overhaul, that's where we look for opportunities for supporting some of their side effects they're experiencing, streamlining some of their medication, empowering them to be able to go advocate with their physician or their clinician as to what changes that they might need to make in terms of their medications. I encourage them to get advanced lab testing done so that they could get a better sense or a picture of what's going on. A great example would be a more comprehensive thyroid panel or a more comprehensive iron panel, advanced cardiac IQ or lipid panel, right? So things like that to help to get a better picture of what's going on so they can make a better decision about how to approach the next steps. And sometimes we do it just with supplements. So sometimes people come to me with their long list of supplements. They've heard this is good for them. They've heard that's good for them. They've sort of started collecting this graveyard of supplements, and they're not really sure which ones they should take, which ones they shouldn't, what's appropriate. So we do a quick little overhaul. We sort of review what makes sense, what doesn't. If there's certain things they really felt like worked for them, I may upgrade them or say, hey, we could combine these two. You don't have to take them in separate doses. This brand actually makes a higher quality version of that. Or sometimes I even honestly, you could probably get that from food better than you can from that supplement. So really trying to tailor it in a way so that it's sustainable. I'm all about the sustainability aspect. I don't want you spending money on more supplements than you actually need just because somebody said it was good. Doesn't mean it's good for you. And so understanding what you need and trying to personalize it as much as possible.
So how can people get in touch with you? You have some interesting social media handles.
So my primary social media handle is at Foodie Pharmacist, spelled with 2 F's. So FOODIE, Foodie Pharmacist. You can also go to my website, larazakaria.com, and you can link back to all my social media as well from there. And you can email me at hello@larazakaria.com.
I think I solved your name problem. We've been on for almost an hour and I think I got it.
Yeah.
Dr. Z.
Dr. Z.
There you go. Now, of course, I want dividends on that and overviews, but
you got it. I hate to break it to you. My students have been calling me Dr. Z for a while.
You could have kept that to yourself. Yeah.
You're just mad you're not going to get the dividends on that.
Yeah. Well, next time around. It's been my pleasure. It's been so informative. We have to have you back on. Everybody, yes. I'm Dr. Rob, and we've got Dr. Z now. We're signing off.
Thank you so much. Appreciate you.